This evening. Got a really good show for you tonight. We will have some good information. Dr. Jenny Powell's been here with us before and given some good info, and we'll get into that in a little bit. A couple of opening things real quick. If this is your first time in the Mill Center, the restrooms are through this door. We have some unsweet regular tea back there and some lemonade, and Anthony and Don, thank you very much for bringing the pineapple upside down cake. I had the smallest piece there was. It was yummy, so you guys go get the rest of it. And there's some coffee back there if you'd like to have that. I'd like to say hello to Representative Franklin, who is here this evening, the 123rd District. Thank you for being here. And woohoo! Hey there. You need some help? Get that in. And let me see here. Okay, so and next month we're going to have a presentation by Mary Hill. She is from the Kansas City area. Patriot, been involved in the movement for quite some time. I've been with her on different excursions in the Kansas City area and up at the Capitol. And she is probably one of the leading right-to-work advocates on the grassroots side that you would find in the state of Missouri. She's got an interesting, compelling story to tell you, and she'll be here. And fascinatingly enough, let's see, that meeting will be on the what is the second Thursday of next month? I know that veto session, if I'm correct, Representative Franklin, is the 20th. Isn't that right?
Yes.
I think so, yeah. So we will have that meeting, right-to-work meeting, before the veto session. So it'll be a timely meeting and be a good thing. I asked the Lieutenant Governor to be here, and they're not going to be here. He can't be here. So, but anyhow, Mary will be here. We're also then going to talk Patty and Charles Knight, one of our members. A couple of our members will be here, and we're going to talk about the Declaration of Independence. If you've never really taken out the Declaration of Independence and read beyond that part where it says all men are created equal, if you read beyond that part, it lays out a good foundation of why the founders fought against the crown the first time. And if you read those things and you put it in context to today, you'll find some pretty striking similarities. But anyhow, we'll talk about that when they come next month. Then in October, we're supposed to have Sean O'Toole. He was a Libertarian candidate for auditor, I believe, last year, or yeah, I think auditor. He'll be here. We're going to talk about property taxes. And then, of course, in November is our turkey and the straw dinner and straw poll for president. We are going to invite every gubernatorial candidate across the state, and we'll see how many show up for that, because we're also going to do a straw poll for governor that evening. There'll be more to talk about that as the time comes. Of course, presidential candidates, just a couple of quick things here real quick. That's a big deal these days. And, you know, John Kasich is out there. He's drawing a lot of support. Something very interesting I want you to look at when you see these candidates. Don't just listen to what they say, but pay attention to what they say, and then look at more at what they're not saying. An awful lot of them talk about how John Kasich, for instance, he lowered taxes in his state and did some other things, and their economy is trugging along, and that sounds good. But he also took Medicaid expansion monies and did some other things. And most of these candidates, from what I hear, very few of them, save Ted Cruz, Rand Paul, and maybe Mike Huckabee, the majority of them are talking about tweaking this little thing or rubbing the edges off of something else and streamlining or updating regulations or closing some of the loopholes in the tax code or simplifying the tax code. Folks, I want someone that is going to eliminate an awful lot of what's going on in the federal government, not just tweak around the edges. So when you look at your candidates, think about that. I know Donald Trump has a lot of traction among a lot of folks, and probably among a lot of Tea Partiers, because he is talking the way that maybe your average angry individual might talk about some things. He's not politically correct, but I want you to also pay attention to an interview he had, and I haven't watched the whole thing, I just saw part of it, but an interview he had with Sean Hannity. I believe it was aired last night or the evening before. One thing I found very, very striking, he was talking about Planned Parenthood. Now, for those of you who are also social conservatives as well as fiscal conservatives, think about this for a minute. He did say that the abortion part of what was going on in Planned Parenthood was horrible, disgusting, and should never happen and probably needs to be defunded. But then he had a caveat that Planned Parenthood is doing some really good things. Now, whether Planned Parenthood is or isn't doing any really good things, the federal government should not be funding it, period. This is something that individuals should do, that private companies should do, and maybe states and local communities should do. There is no provision in the United States Constitution to fund Planned Parenthood, or quite candidly, to fund the Pregnancy Resource Center that we have here in town that saves women from abortion. There is no place for funding of any of those kinds of benevolent organizations in the federal government. So Donald Trump, again, you see, he'll tweak that a little bit, but he's not going to change a whole bunch of it. So think about that when you look at candidates. And that includes gubernatorial candidates as well for the state of Missouri, because I think we can do some downsizing here in the state of Missouri. We went to the watershed meeting. Albert's not here. Albert Hempel's not here. Anybody else in here went to that watershed meeting? And the representative was there, and Karen was there. Yes. So rather interesting meeting. If you have attended any of my discussions on Agenda 21, and we've talked about those sorts of things, this was the very first meeting. And if you want to see how the government uses various tactics, one of them being the Delphi technique, to get the general public to go along and buy in with what they're doing, this is an absolute textbook on how that works. This very first meeting was done just to get everyone familiarized with the watershed approach. How many of you remember the fight against the White River Watershed National Blueway? Well, that was a huge watershed covering most of a big chunk of Missouri and most of Arkansas. Well, the state of Missouri has come up with that same approach, and they have 66 watersheds in the state of Missouri. So instead of fighting that one large one, we're going to have to approach and do something about every one of these. You'll see more information about that as it comes along here in the near future. There is a meeting next week in Preston, Missouri, and a week after that in Buffalo, Missouri, if you'd like to attend. I apologize, I don't have that information here, but get a hold of me after or tomorrow or something, and we'll get that info to you. If you want to attend, you can. This very first meeting was just simply a meeting explaining what they wanted to do and what the plan was going to be. And then their next meeting, they're actually going to bring in a facilitator. And that's where the Delphi technique really starts to come into play. So if you want to see how this stuff works, start attending some of these meetings. They'll have more of them in the future if we don't get it stopped before then, but we're going to work on that. So if you'd like to work on that with me or with us, let me know. I think that's probably all I have for right now. So without further ado, I would like to introduce Dr. Jenny Powell. She has been here a time or two, and she's talked about various aspects of Medicare, Medicaid, and Obamacare. And she was a doctor here in the Lebanon area, and now has a private practice up in Osage Beach. So if you would, welcome Dr. Jenny Powell, please. It's all yours.
I'm a bit shorter. Not too much.
Well, everybody's shy of you, I guess. They don't want to...
I did put deodorant on this morning. I promise, guys.
Just like church, kids sit in the front room.
Right.
Okay, as we wait for this thing to warm up, thank you for that introduction. I'll be presenting something to you this evening that I'm going to have to ask for your patience. First of all, tell me if you can't hear me, because sometimes I talk too fast, and sometimes I talk into my chest or into my nose. So if you can't hear me, let me know. Don't be afraid to interrupt me. If I use some kind of jargon that you're like, I do not know what that means, so stop me and say, what does that mean? Okay, so don't be afraid. Oh, no? Okay. What I'm going to talk to you about this evening is MACRA, the Medicare Access and Chip Reauthorization Act of 2015. And you're going to get this from the perspective of a physician. So I'm sure there are other perspectives that are going to be different from mine, but I want you to keep that in mind. And I want to give a shout out to Dr. Chris Held of San Antonio, Texas, who is one of my colleagues and a fellow member of the Association of American Physicians and Surgeons, who promptly read the entire bill as soon as it was presented to the House of Representatives. And she is the one who declared it Obamacare on steroids and amphetamines. So that's where I get my subtitle. Come on. Hey, there we go. I'm hoping that this doesn't become too heavy because I did bring samples of antidepressants to hand out afterwards.
Cool.
Have some pineapple upside down cake. Save some for later. So, you know who I am. Does everybody have a handout? Okay, good. That's because I don't like to read slides to you. I figure most of you can read, and if you can't read, sit next to somebody who can so they can tell you what it says, because I don't believe in reading the screen to you. But I would like to know who you are. Are there any other physicians, pharmacists, or any kind of mid-level providers in the audience? No? Any hospital administrators? Anybody who works or has worked at a hospital? Good. Any insurance lobbyists? Oh, good. Now we can talk about it. Any insurance brokers? All right, good. We have no insurance brokers? Oh, that's too bad. Because they would really be interested in this. How about any attorneys? No, I probably should have asked that before asking about the insurance lobbyists, shouldn't I? Are there any Medicare beneficiaries in the audience? Okay. Now, I really need to ask your patients, because you need to have a basic understanding about a lot of things before I get into what this law is, okay? And so I have several slides that are nothing but definitions. I promise I won't, like I said, I won't read them to you, but I will point out some of the ones that I think are most important for you to understand. I'll get this down by the end of the thing, I promise. ACO is basically an HMO for the government. CHIP, since that's in the name, you probably ought to know what that is. CMS is our beloved Centers for Medicare and Medicaid Services, an agency in charge of blah, 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 blah. Evidence-based medicine, I'm not going to talk about it, but I thought you might want to know what it is. EHR or EMR, this is very important to talk. This is an electronic health record or a electronic medical record. People will call it different things. Yes, sir.
Would EBM be very similar to best management practices?
Yeah, I guess.
Okay.
What they try to do is take population-based statistics in medicine and then try to say you should apply that to the individual. Okay. Eugenics. I am going to speak just briefly about that, and I hope that I pique enough of your interest that you'll find out more if you don't know what eugenics is. Healthcare. Now you notice I have this italicized. I do want to go through this because this is very important that you know the definition of healthcare. It's the maintenance and improvement of physical and mental health, especially through provisions of medical services. Okay? Then we got the Department of HHS, which we all love so much. HMO. Okay, I thought this one was pretty important too. That's why I bolded it. I made it really, really large. Insurance. The definition of insurance is a contract in which an individual or entity receives financial protection or reimbursement against losses from an insurance agency. Okay? Contract, financial protection or reimbursement, and from an insurance agency. That's going to become important later. MACRA, that's what you're here to learn about. Meaningful use. The only thing I'll say about that is see that it says that it was for the purpose of incentivizing the implementation of electronic health records. That was their stated purpose. MIPS will be discussed slightly. NPI, the only thing I want to tell you about NPI, notice it says that that was a standard of unique identifiers for providers. Evidently, our state's license number is not sufficient. We have to have a national, it's kind of like national animal identification for physicians, except I don't think they were going to chip us.
Yes.
Yet. Okay, the beloved PPACA. I will refer to this as the ACA, just because. And I know what you guys will refer to it as, so I just wanted to have that definition there. Payer. Now, notice I also italicized the practice of medicine. This is what I want you to, if you need to, go back and look at healthcare and then look at practice of medicine. The practice of medicine involves diagnosis, treatment, or correction of human conditions, ailments, diseases, injuries, or infirmities, whether physical or mental. Can anybody tell me what the difference is between healthcare and the practice of medicine or medical care, just based on these two definitions? Anything strike you? What's the practice of medicine? What is it that we learned in medical school?
It just seems to be a little more precise.
Diseases and sickness and infirmities and ailments. What is health care?
Maintenance and improvement.
Like
Of
correction.
health.
Yeah.
Okay, so I want you to, if you don't catch anything else this evening, I want you to catch the difference between health and medicine, diagnosing and treating disease. Okay, are we on the same page here?
Cool.
Next page. Okay, we have one more definition, and this is the sustainable growth rate. And we will talk about this in a little bit. Whoop, I didn't want you to miss this. Can you read that? Okay, I heard somebody chuckle, so I know somebody can read it. Okay, good. We're now going to turn to a history of health or sickness insurance, okay? Please stick with me here. I told you I'd figure it out sooner or later. It'll be later. The very first thing I could find that had anything about insurance was all the way back in 1847 in Massachusetts. And they had quite a comprehensive list of benefits that they offered, so I thought that was pretty impressive. I found something about accident insurance during the Civil War, where if you were injured during travel related to a steamboat or railroad, you were covered, which is kind of cool. There were early versions of disability insurance by the end of the 19th century. 1911, the British passed their National Insurance Act, and this is where the term health insurance started to fall into favor. I think a lot of times they did refer to it as sickness insurance as opposed to health insurance. But my favorite story is that very last one on that slide, Baylor University Hospital. In the late 1920s, there was an administrator from the Baylor University Hospital who who did some research and found that people spent more on cosmetics than they did medical care. And he apparently thought there was something wrong with that. So he said, how can we get people, well, he didn't say how can we get them to pay more for medical care, surely he didn't say that. He said, how can we get people to pay for medical care the same way they do lipstick? A little bit every month. And so they started out with some public school teachers. Anybody public school teachers or ever have been? Of course they used them for guinea pigs, right? And what they did was these school teachers would pay 50 cents a month, and in exchange, if they ever had to go to the hospital, Baylor University Hospital would pay for it. Of course, they had to go to Baylor University Hospital. But ladies and gentlemen, that was the beginning of Blue Cross, and also the beginning of marketing of health insurance to groups of employees. In World War II, the feds rationed a lot of things, and factories had to increase their productivity, and so in order to attract workers, employers started adding fringe benefits and adding more and more to those benefits. By the 1943, that's when the federal government got involved, and you could take your premium out of your check, tax-free, okay? And then by the 1960s, that's when employer-based health insurance actually became mainstream. Most Americans just kind of took it for granted that, okay, that's part of being employed, is getting insurance. The Social Security Act of 1935. Okay, we're starting to get to the meat of this. I thought I'd take this from the original act, and I will read this to you. It's an act to provide for the general welfare by establishing a system of federal old age benefits and by enabling the several states to make more adequate provision for aged persons, blind persons, dependent and crippled children, maternal and child welfare, public health, and administration of their unemployment compensation laws, to establish a Social Security Board to raise revenue, and for other purposes. Right, so they can fill in the blanks, I suppose, later. So you note that it's considered old age benefits. This is 1935. What do you guys think was the average life expectancy in 1935? What I found was 60 for males and 64 for females. So if you lived to be 65, woohoo, you could party because you had lived past your life expectancy and you were considered in your old age. Okay? Anyway, there quickly became a concern from employers that the concept of taking money from employers and employees and redistributing those funds might be unconstitutional. So in 1935, there was a case that went before the United States Supreme Court. I gave you the link there. This is a really interesting case, guys. So feel free to go there and read this. But Henry versus Davis was arguing the Supreme Court. And guess what the Supreme Court said?
It was a tax.
It's constitutional as long as it's a tax. Doesn't that sound familiar? But not as insurance. So if you had considered it insurance, it was not constitutional, but as long as it's a tax, it's constitutional. So this is how they defined it. They said it is a tax levied on both employers and employees used to fund the Social Security program, collected in the form of payroll or self-employment tax. Is it a savings account? No, it's a tax. It's a tax. They had to, because they had beneficiaries immediately before they could, get some of those funds from employers and employees, they had to take money out of the general fund to fund the Social Security, and then they started putting it into that fund. So we'll get to Medicare. I thought you were wondering, when is she ever going to get to Medicare? Well, in 1965, July 30th, they had their 50th anniversary, by the way, just last month. It's Title 18 of the Social Security Act, signing the law. And this created Medicare. And I've got the different parts there for you, though originally Part A and Part B was the original Medicare. I want you to note that they call it hospital insurance and medical insurance, okay? So I've got some things for you to think about. First of all, based on our definition of insurance, is Medicare insurance. Remember, it's a contract that provides financial protection, and you get it from an insurance agency. Is it a contract? Did y'all have to sign a contract with Medicare?
No.
No, you probably signed a sign-up form, but you didn't sign a contract. The contract has to be something where this party says that's what they're going to protection from losses. Well, to a degree it is, but if it was financial protection the way other health insurance is, you wouldn't have to have a supplemental. You wouldn't have to have that gap, okay? So I could be convinced that it does give some financial protection from losses, but does it come from an insurance agency?
No.
Okay. So if we look at that definition, it's not insurance. Is it voluntary?
No.
No. Well, it depends. Okay. If you do not want to take your Social Security, you do not have to take Medicare. In fact, you can opt into, and you can actually buy into Medicare if you did not take Social Security. But I am afraid that it's, if you sign up for Social Security and you don't sign up for your Part A, you will be fined. And you will be fined. And you will be fined until you sign up for it. And then there's another, did you have the two handouts, Steve?
One handout, the other one.
Okay, and this other one, it kind of explains that it's very much like the Hotel California, okay? You can check out anytime you like, but you can never leave. If you want to get out of Medicare and Social Security, if you leave today and you're like, that's it, I'm done, I'm gonna opt out, it's very simple. All you have to do is pay them back 100% of everything they have ever given you.
Or you could be a member of Congress.
Well, you run and I'll vote for you.
Okay, but I mean, that gets you out of Medicare part of it, Social Security.
That's good point. Okay, so is it voluntary? Not really. It depends on how you term voluntary, right? Is it a benefit? Do you feel like it's a benefit if it's mandatory? I mean, come on, if it was really that great, would they have to make it mandatory? So you have to, they call you a beneficiary as if it's a benefit. Really think about words, guys, because words are something that that can be twisted and the meanings can be changed, okay? And then my last question, is it constitutional?
If it's a tax.
If it's a tax, and is it a tax, Jamal?
It sure is.
It surely is, yes, it's a tax. So it's, according to the Supreme Court, it's constitutional. Okay. All right. I know you guys don't care because you're not physicians, but you might know a physician, you might see a physician as a patient. So I'm going to go a little bit into how Medicare used to pay physicians. And first of all, they had something called a reasonable charge payment method. Okay, that sounds like a reasonable charge. Okay, we'll pay that. And it seems unreasonable. Okay. Then in 1989, they came up with something called a fee schedule, or a list of prices, kind of like a menu of, okay, this is how much they would pay for this, and this, using all this fancy conversion factors, some kind of magical formula. Okay. And then in 1998, they went to SGR. Remember, that's one of your definitions. That's a sustainable growth rate. And the whole idea of the SGR was try to keep the payment to physicians down because they were seeing those costs skyrocket. So they thought, well, we can find a way to kind of keep those at a certain level and not go crazy with inflation, et cetera, et cetera, et cetera. The problem with the SGR, there was a huge problem with SGR, was that every 2 years, Congress would wait till like the last minute before they decide what they were going to do with SGR. What are they going to do with SGR? And so the AMA is saying, contact your congressman. Make sure they know that they've got to do something. And so, of course, what they would do at the last second, kind of like Michael Jordan, swish, they would repeat it for another 2 years. Okay? And then 2 years later, it would be the same exact thing. I became a physician in 2002, and that's all I have known, is that every 2 years, let's wait till the last second. This year, they waited till the last second, and then they threw MACRA at us. Thank you. Somebody gets my humor. Okay, so it wasn't as simple as making the SGR permanent, okay? There were a lot of other agendas afoot, and I want to walk you through an evolution of an idea, okay, that gave us MACRA. HIPAA. Anybody heard of HIPAA? Okay, have you ever had to fill out one of those forms when you go to the doctor? This is who can know your information, blah, 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 blah. Okay. They said that the goal of HIPAA was to protect the privacy of individually identifiable health information, which includes your name, okay? Their concern was, okay, there's a lot of technology developing, these fax machines and emails and they were concerned about the privacy of the patient. And so they came up with this act. But also within HIPAA, there were a few other things. Notice it says, and this is from official, okay? It sets national standards for the security of electronic protected health information. Health information, okay? So, who can see the patient's records?
Doctors, staff, Chinese, and Soviet hackers.
Right.
No?
Well,
And a few more hackers too.
okay. Whoever you say can see your records, and your insurance company, because by saying this is who my insurer is, and by giving them your card, the insurance company can get to your records, okay? But there's one entity that can get to your records and doesn't need your permission and doesn't even need you to know that they got to your records.
Government.
Federal government, exactly. Okay, so first came HIPAA, then came meaningful use. I have to be very careful because I started calling this meaningless use, and so sometimes I slip into that. Meaningful use was a part of the American Recovery and Reinvestment Act. Remember that? The stimulus package of 2009? It was supposed to incentivize utilization of electronic medical or electronic health records, okay? But I will tell you, what does incentivize mean? Well, the idea was that these physicians would get just enough money so that they could pay for their electronic health records, okay? That was the idea. I have to tell you, the first time I had a hospital administrator walk into my office and close the door and say, Jenny, you just really need to do this. And I said, what's in it for the hospital? Oh, nothing, it's all for the physicians, it's all for the physicians. I said, well, this physician chooses not to have it, thank you very much. And from then on, I was a red-headed stepchild, and I was non-compliant and what have you. Because initially it was voluntary, okay? But hospitals stood to receive $3 to $6 million each. Eligible providers could get up to $44,000 each from Medicare and $64,000 each from Medicaid. They really wanted physicians to use electronic records. Really, really, really wanted physicians to use electronic records. Okay? Is that in here? I could bore you with all the different stages that physicians had to go through. Let me just tell you, stage 1, providers had to hit all 13 core objectives and 5 to 10 menu objectives. In stage 2, they had to hit all 17 core objectives and 3 of 6 menu objectives, plus 9 clinical quality measures from a list of 64. If you ever go to your physician and wonder why they have got their nose in the computer, folks, it's because they have to click all of these things and make sure they have this, 17 plus 3 of 6, plus that was stage 2, and I would tell you stage 3 looks like this. Okay? This is all the things that they have to do in order to get their meaningful use money. So there's been some pushback from physicians, as you can imagine. I don't have any time to spend with my patients. I'm on the computer all day. I'm at the office till 7 o'clock at night, even though my last patient's at 4. Okay. Do you feel the chill in the air yet? Okay. Good, I'm doing something. Okay, then we get, this is a little further in the evolution of the idea. Y'all know this wonderful law that was passed by the 111th Congress, right? The Patient Protection and Affordable Care Act. The term health information technology is used more than 40 times in the law. 40. More than 40. We thought it was about insurance, but it says the purpose is to integrate reporting mechanisms. It amends HIPAA to simplify the process for the administration. And then I want to point out, in bold, the PPACA requires the Secretary of HHS, we just call it the Secretary from here on out, to establish a national strategy to improve the delivery of healthcare services, patient health outcomes, and population health. How many times is the word health used? But this is about insurance, right? By mandating the purchase of insurance, the feds will improve the delivery of health care. Remember, insurance is a contract which provides financial protection against losses from, that you can purchase from an insurance company. Are we beginning to realize that insurance isn't what it's all about? Okay. About half hour in, am I finally going to talk about MACRA? I'm going to write down, because I was going to give you a summary of the law, but it was 5 pages long, and I figured your handout was already long enough. So I'm going to write down the link over here, okay? Talk amongst yourselves over right now. Can you see it? .gov. Bill 114th Congress.
This is all just civil.
House dash Bill 2.
Is this a law or is it just a bill?
On 3/24/15, 2 days later, ironically, while I was with a healthcare coalition in Washington, D.C. to present a one-page how practicing physicians would fix healthcare to the legislative assistants, meanwhile, the legislators are passing MACRA. They passed it on March 26th. They didn't have any time to read this, folks. Okay? None. Zero. Then it was passed the Senate on 4/14/15, Easter break. Okay, Easter break was in there.
Have to pass it in order to find out what's in
And it was signed eagerly by the president on 4/16/15. He was so excited to sign this bill. Remember, this law amends the Social Security Act, because that's where Medicare is, okay? And it is called the Medicare Access and Reauthorization Act. Okay, now, remember that the legislators evidently knew little about it, because none of the legislative assistants that we talked to, they knew they were talking to physicians, they knew that we were talking about healthcare. Not one of them told us that this was happening. Now, that may have been intentional, or maybe they didn't know about it. But apparently, this has been in the works for a little while, behind the scenes, in the administration, because look, I found a CMS.gov published a fact sheet. They published a fact sheet on 3/25/15, the day in between when it was introduced and the day it was passed by the House of Representatives, saying, you know, it was called Healthcare Payment Learning and Action Network, working together to move payment toward value and quality in the U.S. health system, and it was exactly what is in MACRA. Sure. Here's how patients or physicians will be paid. First of all, we have to redefine physician. Now, I have nothing, you know, I have absolutely nothing against my physical therapists. I love them dearly. I have nothing against chiropractors or podiatrists or oral surgeons, but physician is not found in the law but twice. First, in defining what an eligible professional is, and I'll tell you what the second one is. But an eligible professional is a doctor of medicine, doctor of osteopathy, doctor of podiatric medicine, doctor of optometry, doctor of oral surgery, doctor of dental medicine, doctor of chiropractic, physician assistant, nurse practitioner, clinical nurse specialist, certified registered nurse anesthetist, and anesthesiologist assistant, certified nurse midwife, clinical social worker, clinical psychologist, registered dietitian, nutrition professional, audiologist, physical therapist, occupational therapist, and qualified speech language therapist. Okay? These are all now eligible professionals. So anywhere when you go to this law and you look at it and you see eligible professional or EP, this is who they're referring to. So we're all bundled into one nice little umbrella. Okay? slides here actually from the law regarding pay that I want to point out to you. Total performance will be assessed in a method developed solely by the Secretary of HHS. And each eligible professional will be given a score from 0 to 100. And then they will apply an adjustment factor to that score for the year. And that's what the payment will be based upon. The Secretary shall develop the methodology for assessing this and figuring out how this scale should look. Payment for covered services made to an eligible alternative payment entity rather than directly to the qualifying participant. This means that physicians will no longer get paid directly from Medicare. Physicians or eligible professionals, will be paid through an eligible alternative payment entity. This would include like an ACO. So if you're a hospital, if you're a physical therapist or a physician who works for a hospital system that's an ACO, you're going to get paid through Medicare. But I would like to know what happens to, for instance, okay, now her name just totally went out of my head. Dr. Ostenfeld. She doesn't work for a hospital. She's an independent private physician. How is she going to get paid for Medicare, by Medicare? Unless she, says, well, my business should be an eligible alternative payment entity. Well, guess who that's going to depend on? That's going to depend on the Secretary of HHS, whether that is eligible or not. Yes, sir.
Could you go back one?
I can.
MIP shall apply to payments on or after. Now, that is a merit-based system, right?
Yeah.
Who determines the merit?
Huh? Yeah. That's,
bureaucrats?
Yeah, the Secretary. That's how this total performance will be.
But,
It'll depend on whether you remember meaningful use.
Yeah.
Okay, that's just part of it. But you've got these other quality issues that you have to do. They will determine, based on your performance for how you did this last year with Medicare patients, based on all of their little bullets, they will give you a score.
So these are doctors working for the Secretary that's figuring out what other doctors are doing, right? Yeah.
Of course. It's the Secretary shall.
Yeah.
Secretary shall. So this next one says that they'll be paid through this alternative payment entity, and they'll be paid on an annual basis in a lump sum.
Wow.
Now, I have not yet determined whether that means for all Medicare recipients they'll get, the provider will get, or if it's, per Medicare beneficiary. I haven't learned that yet, nor will I probably until I talk to one of my fellow physicians. And then, here's the only other place where a physician is used. This excites me. I was telling a group of physicians this. I said, oh, look guys, we get to be physicians again. But only when they publicly report your provider score on the Physician Compare Internet website.
What happened to HIPAA?
Oh no, this is the provider score. Yeah, this is a provider score is going to be publicized. So we're going to praise those who have been good little monkeys and have clicked all the things, and we're going to scold the bad monkeys.
Exactly.
I hope that I have a negative number.
And that has nothing to do with care. All that has to do with how many checks you put on the boxes in the...
Ding, 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 ding.
Well, that's cool.
Excellent, because it's not about medicine, remember?
No.
It's about health. All right. So what about, I already asked you about independent physicians. That's one of my concerns. Oh, but what about private plans? This only has to do with Medicare, right? Except, if you look in the body of the law, by 2021 and 2022, the Medicare payment plan is expanded to include the combination all-payer and Medicare payment threshold option. What does all-payer mean, guys?
Single payer.
It means, well, essentially single payer, but it means all insurance plans, which by that time there may be only one private insurance plan anyway, since they're all getting bought up. Okay?
Wow.
So by 2022, this is how all physicians are going to be paid through insurance. And that's not that far away. Can you read that? Please tell me you can. That's from Monty Python on Double Week Rail. Don't tell me you're bad. I didn't vote for you. Even more concerning to me, however, is the concept of interoperable national health information infrastructure. That is one of the main purposes. That is the evolution of the idea that I've been trying to talk to you about, is they want to develop an interoperable, that means throughout the country, right? National, throughout the country, health information infrastructure. And because this is one of my passions, folks, I am concerned about your privacy and my patient's privacy. In order to get paid, ultimately, by any insurance plans, the physician must allow full disclosure of confidential patient information to the government via interoperable electronic health records. HHS, I cannot make this up, guys. This is too bizarre. I cannot make it up. HHS can then sell this data to qualified data entities.
I repeat, what happened to HIPAA?
But HIPAA doesn't apply to the government.
Oh, that's right, I'm sorry.
And qualified data entities is to be defined by the Secretary of HHS. In other words, all medical records will be available to the Secretary of HHS and anyone the Secretary wants to either give it to or sell it to. So what happens to the sacred patient-physician relationship when the physician is reduced to an eligible professional and a data collector at the bidding of the Secretary of HHS? Almost makes me cry.
Now, when is this going to start?
They're going to start phasing it in next year. And then by 1/1 of 2019, all Medicare payments will be done that way. So they're going to phase it in a little at a time. I'm reminding you of your Fourth Amendment. Yes, sir.
So then by 2022, it said all payments had to go out. So does that mean that how's that going to work?
Uh-huh.
So that means all insurance payments from all insurance companies? So they're going to have to pay into the feds, and then it's a clearinghouse, isn't it?
It's a clearinghouse, yes. If your private medical records is not considered private property, what is? Don't expect a government who ignores the Fourth Amendment in the name of national security to suddenly care about the privacy of your medical records. MACRA will extend to those like me eventually. I don't bill Medicare, I don't bill any insurance. I saw something coming down the road and I said, I don't want any part of it. Meaningful use was the straw that broke this camel's back. And I could see that this was going to be a very head thing. But it is going to touch me because I do have some patients who are Medicare patients. They just choose to be my patient, okay? I don't bill Medicare, can't send anything in for Medicare. But this is how it's going to affect me. Education for physicians and providers, right? Well, beginning in 2016 and on, Medicare beneficiary prescriptions, that's what RXs mean, prescriptions must be prescribed by a provider with what the Secretary determines to be a valid MPI. And by 2022, this will apply to private insurance as well. So this means that a physician licensed to practice medicine in the state of Missouri could have prescriptions not covered solely because the Secretary of HHS deems that the MPI is invalid. That makes my blood boil because I'm licensed by Missouri. That the Secretary of HHS could be the one who could say that my MPI is invalid and therefore I'm not going to pay for your prescription. The patient wants to pay for it, that's fine. But since you're the one who prescribed it, we're not going to recognize your MPI. Folks, don't believe any member of Congress when they say that they too oppose the Affordable Care Act, when they so easily passed MACRA without even knowing what was in it. You know, all of these, oh yeah, here's the next one. this is some of the folks who really supported both the ACA and MACRA, okay? The AMA, which I do not belong to, couldn't pay me enough, was like so excited. This is the doc fix, is what they called it. They, all the way down to our Missouri State Medical Association. Oh yes, we want this, this is the end of SGR. This is going to take care of it. And sure, if you follow all of their little bullets and you jump through their hoops, you will get a 5% raise. How exciting is that? But if you ask me, it's a doc fix like you fix a dog. How do I really feel about it? Am I a little passionate? Yes. Okay. I have a huge problem with MACRA. I promise I'm going to get to the end of this. I have a huge problem with MACRA, not only because of the privacy, but because of what I feel is the underlying agenda. Now we're going to get. Along with everybody in my graduating class from medical school, and on the back table is my Hippocratic Oath, the one that I took when I graduated. Physicians take a Hippocratic Oath. They may vary, and it's not exactly like Hippocrates, his. But there's some things that are essential in that Hippocratic Oath to treat patients to the best of one's ability, to preserve patient privacy, to preserve the sacredness of life, and to focus on the individual. Okay? That is what we are taught. That's what we swear an oath to, is to the individual. I believe the problem, folks, is a problem of basic philosophy. Physicians care about individuals. Okay? When we want to be more concerned about society as a whole, the public, somebody who focuses on the individual instead is an enemy.
That's right.
Eugenics. I told you I was going to touch on this. Has everybody heard of eugenics? They know what it is?
Give a brief description.
Okay, well, they have a definition in there, but it's pretty much like, you know how you breed your cattle and you try to breed good things into the cattle using genetics?
Breed out the bad.
Right, you want to breed out the bad, breed in the good. That's the difference between positive and negative eugenics, by the way. Positive eugenics is breed in the good qualities, negative is breed out the bad qualities. But eugenics applies to human beings. Herein lies the difference. They refer to it as social Darwinism, which is kind of using natural selection. If you know anything about the Darwinism, it says that, you know, that's why the giraffe has a long neck, all right, because that helped them get to the top of the tree. So those traits were passed down, right? And then the little short giraffes died off because they couldn't eat. That's my summary of Darwinism and natural selection. Sorry, I didn't want to hear it. This was a very, very popular movement. Okay, it started in Great Britain, it came to the United States, and it was very popular. In 1926, the foundation of the American Eugenics Society focused on eliminating the negative or undesirable traits in society, especially of the poor, the uneducated, and the minority populations. It was a popular belief system which led to widespread forced sterilization and reinstitutionalizing of undesirables. Okay? In 1927, there was a Supreme Court case. Oh, guys, there's entire books about this case. And it was Buck versus Bell. And quite frankly, Carrie Buck was a 17-year-old unwed mother who was going to be the very first person to be forced to be sterilized by the state of Virginia because they deemed that she and her mother were feeble-minded and sexually promiscuous. And so that she needed to be sterilized so that no more of this bad traits were going to filter through into the state of Virginia, okay? And so it went to the Supreme Court because there was somebody who said, I don't think this is constitutional, guys. I don't think you can force sterilization. It was upheld. And the famous Justice Oliver Wendell Holmes said basically in his statement that 3 generations of imbeciles are enough. After that, by 1931, at least 28 states had compulsory sterilization laws. You want to know about Missouri? I am so proud of Missouri. 3 times they tried to pass forced sterilization laws in Missouri. But what finally, the opposition, they just couldn't do it because there were enough legislators in Missouri who said, you know, we really don't know about this hereditary stuff. We don't know enough about what can be passed on and what isn't passed on. And so they didn't think it was right to force sterilization on somebody when you didn't know the real science behind it. Thanks, God. Undesirables, of course, could be all kinds of people. Whoever the group of people who were in charge thought was undesirable. It was usually those who were poor, those who were mentally or physically handicapped, if you had bipolar disorder, if you were a criminal, if you'd ever been, you know, if you were a chicken thief. That was one of my favorites, if you were a chicken thief.
Then we elected us.
Yeah, well, I'll get to that. I'm not going to read this to you, but I think you need to read it. This is a quote from Margaret Sanger, where she talks about advocating for birth control. I believe in birth control, come on, you know, but this is the agenda behind birth control. It was because she was a wild eugenicist, believed so much that there was this whole undesirable portion of society that needed to be bred out, and so we need to make sure that they have birth control. Because, unfortunately, you know, the rich people, who are the people that we really want to have children, they can't have children, but for some reason these poor people can just pop them out like anything. So let's provide birth control to them for little or no cost. She was the founder of the American Birth Control League, which changed its name in 1942 to Planned Parenthood, and she opened her very first clinic in Harlem, New York. Guess what portion of the population she wanted to see gone?
Imagine
Okay, perfect race. Does this sound familiar? Anybody? Perfect race? After World War I, they were in a world of hurt in Germany, not just financially, but there were a lot of medical crises. And they were concerned because they thought that maybe the war had decimated their country of the strong and had left the weak there to survive. And so there was a change in the mindset of physicians, okay? They went from being focused on the individual to that suddenly they had to be focused on the good of the country. Okay, exactly, the collective. And they had to worry about was the cost of keeping someone alive worth it to society. Now you remember the difference between healthcare and practice of medicine, right? Have I got this in here? Okay. Goebbels was the propaganda chief for Hitler, and I am going to read this slide to you guys. He says, our starting point is not the individual, and we do not subscribe to the view that one should feed the hungry, give drink to the thirsty, or clothe the naked. Our objectives are entirely different. We must have a healthy people in order to prevail in the world. Healthy. What kind of evil can be done when it's for the benefit of society?
just about anything.
But we had the Nuremberg trials, right? So that's when eugenics went away, correct? We don't have any of that here. Oh, wait a minute.
Yeah.
Can you read back if I can?
Yes, I will. On the left, we have a gentleman who says, society's needs come before the individual's needs. Adolf Hitler. On the right, we have a lady who says, we must stop thinking of the individual and start thinking about what is best for society. Hillary Clinton. So this is dusty past history, right? Let me just point out a couple of things to you. The Bill and Melinda Gates Foundation has publicly stated that one goal of their vaccination agenda is population control. 100 Ironically, when there's this area in Africa where they've been vaccinating against a certain disease, but now they're seeing their birth rates going down.
Really?
Every child who wants a child is a term coined by Frederick Osborne, a leading eugenicist of the 1950s. And that term was adjusted by Planned Parenthood and is prominently featured by other eugenic organizations such as the United Nations Population Fund. And you all, if you come here, you know a little bit about Agenda 21, right? There's just far too many people in this world. The belief that there are too many people will lead to a need to ration resources. Resources need to be rationed or not. They dumped sugar in the Pacific Ocean, guys, as my parents and grandparents were rationing it to create concept of a shortage.
Dusty past history. Karen, Representative Franklin, what did that individual from the Missouri Department of Conservation say the best way to control and keep the environment clean at that meeting? Do you remember? He said control the population, did he not?
Said eliminate part of it, yeah.
Yeah, he said eliminate part of the
The
population.
real answer to the problem, it says, is it something we can't do, but it says the real answer is 2/3 of the people need to go away.
So he would probably...
We don't have any volunteers, so now we have to try to do this.
So, this isn't...
He said that 2 or 3 times.
That's right.
He didn't say it once, he said it twice.
At least. So this isn't an old concept, folks.
Is that his name?
I still probably do have a name, but I don't have one.
Send it to him.
I do want to ask you, if your goal was to reduce the population of the planet, think of the different ways that you would achieve that in the United States.
Oh my gosh.
One way, you suppose, is to take your social policies and your health care policies and to make them one.
Of course.
And everything must come through that interoperable health information infrastructure. I assure you that as a physician who has sworn to care for individual patients, I cannot support any program that sacrifices the rights, concerns, and lives of individuals. In exchange for the greater good of society. And I thank you for your attention.